Talking about the ectatic conditions of the cornea, when we state or when we term these conditions to be ectatic, what does the word ectatic really means? It basically is derived from the Latin origin and it is meant for prolongation or elongation that is meant over here. Now, this elongation over here is just subjected to the cornea. So when we say the ectatic conditions that are relating to the cornea, we mean that there is some sort of a protrusion that is related to cornea. Over here, there are very notorious conditions which we are going to study today that are relating to cornea and that basically present to you in the outpatient departments as the outward protrusion of the cornea. So it can be just the axial protrusion of the cornea, which is termed as keratoconus, or either it can be an overall protrusion of the cornea, which is also termed as keratoglobus. So these are the two most notorious ectatic conditions relating to the cornea. Cornea, as we all know, is the transparent structure which is lying just in front of the iris as well as the pupillary window and obviously the lens. So these three structures are basically in line when we are considering cornea. The main function of the cornea is obviously to pass on light and to pass on the imaging to the lens, and obviously the refraction takes place and then a final image is formed on the retina of the individual. So if there is any sort of abnormality which is related to the corneal surface, we've already gone through the separate discussion, a separate entity which was regarding the corneal ulcerations. Again, the corneal surface was damaged in that case. So over here, we are relating to the shape of the cornea. So there can be certain pathological conditions which can result in the disturbance of the shape of the cornea. And again, it is going to affect the vision of the individual. And that is going to be the main symptomatology over here in cases of ectatic conditions of the cornea primarily. So over here, as you can appreciate even in this diagram, that we have the iris, and which is basically just in close relation to the pupillary window. And then obviously we have the cornea that is situated right anteriorly, right in front of the pupillary window. So if it's basically in a normal condition, it's just going to be a convex surface, a transparent. This is one of the prime condition that is related to the functionality of the cornea. It has to be transparent in either cases. Any cloudiness, any haziness, if it is found in the surface of the cornea, it is going to blur the vision of the individual. So this is going to be the rule of thumb that the cornea has to be transparent at any case. And on the other hand, there has to be a proper convexity that has to be maintained at the corneal surface. If this convexity is disturbed, for example, if there is any sort of protrusion that you observe at the corneal surface, if it is abnormally protruded outwards, that is in this direction anteriorly, then that would be regarded as an ectatic condition of the cornea, and that is again going to blur the vision of the individual. Now, why does this happen? This happens due to the fact that there is going to be the differences in the refractive index of the cornea, and there are going to be features of astigmatism whenever the shape of the cornea is disturbed in these individuals suffering from keratoglobus, or either if they are suffering from keratoconus, which are the two most common conditions that we observe in the outpatient departments. Obviously, we have certain other conditions, for example, the posterior protrusion of the cornea. So it can be in either directions, either anteriorly or posteriorly, but most importantly and most commonly, we see this protrusion in the anterior direction over here. So this is the most common presentation, and you should be well versed how to treat these patients and how to first of all diagnose if a person is suffering from keratoconus or if this particular patient is suffering from keratoglobus or not. This is the mainstay over here. Then obviously the aqueous humor has to be observed. Again, the cornea is in close relation to the anterior chamber, which is filled up with the aqueous humor. So if there are any states of infections that are relating to aqueous humor that are also going to be seen or that are also going to be documented over here. Again, if there are going to be conditions of keratoconus and outward protrusion of the cornea, there can be the states of glaucoma that are associated with these kind of conditions. So again, it is not just a typical isolated picture that a person is suffering from keratoconus or if a person is suffering from keratoglobus. Usually, you would observe that these children would develop this kind of a condition, and usually they are suffering from some sort of a systemic illness as well. For instance, usually the children born with syndromes, for example, Down syndrome, Morphin syndrome, Ehlers-Danlos syndrome, all of these children would usually present with the development of keratoconus with the passage of time, obviously not by birth, but they're going to develop it with the passage of time. Usually the presentation is in the early adulthood. So this is the prime presentation. When you have a look at this patient, you would know that this patient has been suffering from some sort of a hereditary or some sort of genetic problem as well. This would be a typical picture that you'd observe that there is an association with these kind of syndromes and the presentation of keratoconus in these individuals. Usually, keratoconus is a non-inflammatory condition. When you would look for the signs of inflammation, for example, any signs of redness or chemosis, or either any sort of discharge in these patients, you'd observe that they are free of all of those signs and symptomatologies of any acute or chronic infections in these cases. So it's a non-inflammatory condition, although it can be coupled up with inflammatory conditions in some individuals. Then it's quite an uncommon condition, one of the most important factor over here that you usually do not come across these patients quite commonly. You can also state it in another words that usually you misdiagnose these patients or they are left undiagnosed most of the times. The diagnosis of keratoconus or any other ectatic condition of the eye is related to when you look at the cornea alongside a slit lamp. It cannot be a naked eye diagnosis. So it's again very important. Whenever I use the word an outward protrusion of the cornea, we can just have a confusing picture of a person who is suffering from proptosis, which we have discussed as a separate entity. How can you differentially diagnose whether this person is suffering from a whole and whole protrusion of the eyeball in the forward direction, which was known as proptosis or exophthalmos, or either he or she is suffering from some sort of a bullous condition, for example, the outward protrusion of the cornea, that is the keratoconus or keratoglobus. So this differentiation, there is a thin line of differentiation over here. Usually proptosis can be even diagnosed on a naked eye examination. But when you discuss this kind of the ectatic conditions of the cornea, these cannot be diagnosed on the naked eye examination. Rather, you would have to have a complete examination through a slit lamp. That is necessary over here. Now, the typical features that you're going to look for, the signs of keratoconus over here are again very important. And we'll be going through, you will be starting through the periphery. You're going to look for the signs of warts over here, right on the periphery of the cornea. So there is going to be the signs of the Fleischer ring. This is one of the ring formation that you would observe in these patients. And then obviously, you're going to observe that these patients are having some sort of a warts line that you already observed in cases of a senile depigmentation or degeneration in the eyes of the older aged individuals. So if there is any, if there are any juvenile signs in these individuals, they are basically related to the degenerative processes that are related to the cornea of these individuals who are suffering from keratoconus or either they are suffering from keratoglobus. And we'll be discussing the different examination techniques alongside. How do you then have a definitive diagnosis in these patients? How do you confirm the diagnosis of keratoconus or either keratoglobus in these patients? So this is in close relation to the lens as well. Now, as the word keratoconus is indicating, it's basically the conical shape of the cornea that is regarded as, or that is termed as keratoconus in these individuals. What can be the basis of the formation of this conical shape of the cornea? Usually, there is a genetic predisposition towards the development of this conical shape. So it's basically a kind of a hereditary disease that the patient is suffering from. On the other hand, it can be a degenerative process that is happening or that is basically a part and parcel of an inflammatory process that is going over there at the level of the cornea. Then there can be some sort of endocrine abnormalities that the patient is suffering from, and they are presenting as the case of keratoconus in the departmental view or in the outpatient department. So it's again very important to take a proper history from the patient, and that would highlight the particular causative factors towards the development of this kind of a pathology at the level of the cornea. Whatever the case is, the patient is going to present in the outpatient departments with a blurred vision. Obviously, he or she might not be knowing the shape of the cornea has changed, or there are some degenerative processes that are going on. It would be basically the presentation with the blurring of the vision. Now, this blurring of the vision is a part and parcel of the indefinitive changes at the level of the astigmatism, and that are resulting in a blurred vision in the individual. That is why when you manage these cases, the treatment guidelines usually consist of giving off rigid contact lenses. They're also known as the rose contact lenses. It's one of the variety, but usually the patients are not quite compliant with the use of these kind of contact lenses, the rigidity of the contact lenses, and patients present to you with signs of irritation or redness in the eyes or even in the conjunctiva. So this is the usual presentation, and this is the usual treatment guideline. Nowadays, we are performing keratoplasty procedures for these individuals, and they have an amazing outcome for these individuals. So again, to have a proper history, to have a proper examination in these patients is the mainstay over here. The configuration of the cone-shaped cornea takes the shape of a conical shape over here. As you can appreciate in an anterior-posterior view as well as in a lateral view specifically, it's very importantly and very significantly, it can be appreciated that the shape of the cornea goes about in a conical manner, having an apex and having a base as well. So the basic investigations or the basic findings are related to this base of the conical shape, where we can find the Watts line as well as we can find the Fleischer's ring. When we make the patient sit on the slit lamp, we are going to observe for these signs of the conical shape of the cornea. For instance, we're going to look for the oil drop reflexes over here. Then we have the Fleischer's ring, and on retinoscopy, you're going to look for any early signs of keratoconus as well. Now, there is a very interesting term which is used for the earliest signs of keratoconus, which is known as the formi frustae apparens. So it's quite difficult to differentiate a normal cornea from a conical shaped cornea, which is in its early phases. Again, you're going to appreciate the signs over here, and the slit lamp examination is going to be the diagnostic factor over here when you're going to look for any signs of keratoconus in this particular patient. The etiopathogenesis. So, what are the factors which can contribute towards the development of keratoconus? You can just remember one thing that is quite basic and that is quite simple over here, that the development of keratoconus starts off from the process of a microtrauma. So there is going to be some sort of a microtrauma that the eye is being subjected to, and then there is going to be a genetic predisposition of the person himself or herself that is going to make the patient more prone to the development of a conical shaped or the any abnormality that is relating to the shape of the cornea. So it's again very important how you differentiate and how to have the exact etiopathogenesis in these patients. In a lot of individuals, this kind of a condition is a developmental condition, or it can be even a degenerative condition. So you have to look for the factors, whether it is just a developmental or a hereditary condition in this individual, or either there were some triggering factors from the eye of the individual, from the neighboring structures, from the environment that resulted in the kick-off of the degenerative conditions in the eye of the patient. So that is how you investigate these cases and get to the definitive etiopathogenesis in these cases of keratoconus over here. Again, the hereditary dystrophy is very important, and you look for the endocrine anomaly as well. So whenever you are just fearing the fact that the person was genetically predisposed, we obviously regarded that the patient was genetically predisposed and the incident of some sort of a condition. For example, it can be a long-standing infectious condition. It can be any cases of proptosis, which ultimately resulted in the development of keratoconus in these individuals. We've already discussed that the development of proptosis is through multiple factors. It can be the development of infections, trauma, it can be the malignancies at the back of the eye. The soft tissue malignancies can result in the outward protrusion of the eyeball. The microtrauma resulting through this outward protrusion of the eyeball is again going to start off with a vicious cycle of the development of keratoconus in these individuals. So all of these incidents are basically interrelated, and they result in the development of a cone-shaped cornea in these individuals. On the other hand, we have endocrine anomalies as well, and they can even result in the development of keratoconus in these individuals. So when we regard the endocrine anomalies, the most notorious of these endocrine abnormalities or the is basically the hyperthyroidism over here. So even the development of the Graves' disease, which is another form of hyperthyroidism, the patients usually present with a typical condition of exophthalmos, that is the outward protrusion of the eyeball, and these patients can even be predisposed to the development of this conical cornea or the outward protrusion of the cornea, which is termed as keratoconus in these individuals. One interesting fact over here is that even if the patients are not suffering from any sort of developmental hereditary abnormality, or you have taken a detailed history and you got to know that the patient has not been suffering from any sort of a degenerative disease either, then you can basically look for any signs of LASIK surgeries. So LASIK surgery complications usually are presented as keratoconus in the clinics. So it's one of the very important factor in the history. You have to rule out any recent ocular surgeries. Even this development of the LASIK surgery, the laser surgeries, or even any sort of invasive surgery can make the eye of the individual more prone to the development of this abnormality in the shape of the cornea. So these are the things that you're going to focus on when you're going to take the history from the patient and you want to analyze what are the predisposing factors for the development of keratoconus in these individuals. So these are the basic points that you're going to consider for this patient. Now, leading on, we should know the basic pathogenesis or the pathogenetic factors. We know that basically the development or the elongation or the prolongation of the cornea is due to the thinning of the wall of the cornea. Regarding the histological layers, we know that we have a stratified squamous epithelium, which is on the most outer surface, or the surface that is basically in contact with the environment is the stratified squamous kind of epithelium of the cornea. Now we have a trite junctions of the columnar cells, and that is basically in close relationship to the stromal layer, which in turn basically is lying or resting upon the Descemet's membrane. So it can be the any of these layers which is involved in the development of the keratoconus. One of the condition which is known as the development of the hydrops is basically whenever this abnormality or this protrusion involves the Descemet's membrane, then this kind of a condition is known as the development of hydrops, which is also associated with an increase in the intraocular pressure, and there are going to be slight changes in the anterior chamber as well, and people with hydrops usually develop the cataract as well. So these are some of the syndromic conditions that you should consider as well, and which are most anomalously known as. Then the pathogenesis of the keratoconus, if we look at what are the pathological factors over here. Over here, you can appreciate how a healthy cornea looks like. And then we have the development of keratoconus or the outward protrusion of the cornea, which is known as keratoconus cornea. Now, all of these changes at the level of the shape of the cornea, they develop due to the thinning of the corneal wall, corneal thinning and loss of the structural integrity. Now, this loss in the structural integrity is due to the secretion by the lacrimal glands. There is this prolactin-induced peptide structure which contributes towards the corneal thinning and loss of the structural integrity, as well as sometimes the salivary glands are responsible for the production of this PIP, that is the prolactin-induced protein structure, resulting in the corneal thinning, loss of the structural integrity, and obviously there would be an outward protrusion of the corneal wall. So this is the basic pathogenetic factors that you would consider for these patients. Again, it's very important that you look for the features. For instance, you're going to look for a Fleisch's ring, you're going to look for any sorts of warts line that you can observe in these patients, as well as on retinoscopy, you're going to look for the earliest signs of the scissors reflexes specifically. Now, what do we basically mean by these scissor reflexes is that there are the typical positioning of the shadows when we perform the fundoscopy, that is a direct fundoscopy on the individual. You see that there is a typical motion of it is just resembling a scissor. As the scissor moves, it is resembling that movement, and this motion is basically considered as a scissor reflex on retinoscopy. So these are the typical signs, or these are the typical features that you're going to look for on examination or on a detailed examination of the patient. The PIP levels are regulated by sex hormones, and that again can even contribute towards the loss of the integrity of the corneal thinning in these individuals. So regarding the pathogenesis over here, the night compression or the dry eye or even the atopy can result in the surface inflammation, and that is basically the development of the contact lenses, or even the pollution in the environment can even contribute to the development of the surface inflammation. So this is one of the key incident over here. The development of surface inflammation is the key factor that we're going to consider. It can be due to any sorts of pathogenesis that the person is suffering from. For example, the dry eye syndrome, or even the atopy of the eye, the night compressions, the use of the contact lenses, the polluted environment can contribute towards the development of inflammation at the corneal epithelium. Then obviously we have a computer vision syndrome, which is a kind of an astigmatism that the patient can suffer from. It's quite compulsory and it can result in eye rubbing. There is a constant irritation when there are prolonged hours of the individual, history of prolonged hours, working on the laptops or computers. There is a chronic irritation that is caused in the eyes. It results in the eye rubbing quite frequently, which can be a cause of a micro trauma, and again it can result in the inflammatory slight inflammations of the cornea. Whether there is just a mechanical irritative purpose or an episode or an inflammation, it is going to the production of the heat at the corneal epithelium. Again, eye rubbing can also contribute towards the impaired surface barrier. Then there can be the cell mechanosensitivity is increased, the hydrostatic pressure is increased, and there are shearing forces that the patient is suffering from. The heat is going to basically degrade the extracellular membranes. So whatever the epithelium is, we are talking about a stratified squamous epithelium over here, but still it is going to cause a degradation of the epithelial cells over here. Again, in return, it can be a collagenase enzymatic activity, which comes into action in such an instance. The impaired surface barrier can initiate the process of apoptosis in these individuals. So this is basically a cell death phenomena. Apoptosis is the death of the cells. So there is going to be the initiation of the inflammatory processes, the production of the heat, which is going to in turn result in the cell death of the corneal epithelium. So these are the key incidents that you have to look for over here. And then we have, if the hydrostatic pressure is increased, we have a viscoelastic prostaglandins, ground substance displacement, which is another key factor over here. The shearing forces, they again cause the development of these prostaglandins, or either there can be a fibril and a fiber slippage over here. So these are the key events. These events that are shown over here in line over here, these are the key events of the pathological or the pathogenesis, which is making the basis for the development of an abnormal shape of the cornea or an elongation of the cornea over here. Again, in return, any kind of a cell death, any kind of an extracellular membrane degradation is going to result in the reduction of prostaglandins and microfibrils over here. This reduction in the prostaglandins or the microfibrils is going to result in the reduction of the collagen maintenance. As a result, the collagen maintenance is disturbed and it is going to eventually result in the stromal thinning. So the stromal wall, or there was an extracellular membrane and it was in close contact with the stroma. When you recall the histological layers of the cornea, you get to know that in the process of the keratoconus or the development of the keratoconus, there is going to be the degradation or the thinning of the stromal layer as well. So this process is not just limited to the epithelial membrane. It is also going to involve the deeper layers of the cornea, involving the stroma, involving the Descemet's membrane as well over here. Then obviously we have the corneal weakening, which is also associated with this corneal thinning or this stromal thinning phenomena. And then finally we have the transient deformation. So it's not a permanent deformation that results initially. It is a transient deformation, which in turn, if it is a progressive degradation process or if it is a degenerative process that is continued, then only it is going to result in a transient deformation, or there are going to be the abnormalities of shape that are noted down for this kind of a patient. So this is quite a summarized kind of a flow chart resulting in the key events or enhancing the key events for the development of the keratoconus in the patients. And what are the underlying mechanisms? So it's again one of the very comprehensive way to define or just to have an explanation of the development of keratoconus in the individuals. So these are this is the basis for the development of keratoconus. And now moving on to the clinical features, we are going to look for the defective vision. The history is going to lie upon the fact that the patient is going to complain of a defective lesion, a decreased vision, a blurred vision that appeared in the patient. Irregular astigmatism, so these are the peculiar features, and then obviously the patient is going to have a progressive myopia as well. So these are the key complaints that you're going to look for when you're taking the history from the patient. And then only obviously you're going to associate these features from the other contributing factors that can lead to the development of keratoconus in these individuals. The signs, as an ophthalmologist or even as a GP, general practitioner, you should know what are the typical signs that you're going to look for a definitive diagnosis of keratoconus in these individuals. First of all, the window reflex is distorted. So what is window reflex and how do you define this window reflex? It's basically the checking, or the ophthalmologist is basically checking the neurological deficit of the individual. So the corneal blink reflex is also known as a window reflex. And again, if the cornea of the individual is sensitive enough, or if there are no neurological deficits in the individual, the blink reflex is a normal phenomena. So if it is distorted in any case, that is going to highlight the fact that the epithelium is not in a proper manner, or it's not working in a normal condition. There are some degenerative processes, or either there are some sort of inflammatory conditions that are relating to the cornea, and that is resulting in the absence of the corneal window reflex in the patient, as well as the annular dark shadow, or the patient is also having an oil drop reflex. That is again the Fleischer ring, or the development of an annular ring relating to the periphery of the cornea is going to be presented as this oil drop reflex in the individuals. Then obviously, you're going to look for any signs of the thinning of the cornea. It can be ectasias and the Watts line. Watts line, if you can remember, we just discussed in detail the development of Watts line when we discussed arcus signalis. Arcus signalis is basically the degenerative processes that are occurring with the old age. So it's the periphery of the cornea that you observe the appearance of this silvery ring that appears at the periphery of the cornea, and that is related to the age-related degenerative processes in an individual. So usually, if there are some juvenile presentations of the Watts line, that is basically regarding to the fact that this patient is suffering from some sort of an abnormality contributing towards the shape of the cornea. So this is the mainstay over here. And then the yawning reflex, which is also known as the scissor reflex. Now one has to remember the key factor over here, that this scissoring reflex, which is also termed as yawning reflex in the individuals, is only seen on fundoscopy or retinoscopy of the individuals. So when you're going to observe the retina of the individual through a direct ophthalmoscopy technique, only then you can observe that there is this motion of the pair of scissors, which is noted down at the back of the eye on the retina, which is related to the development or the diagnosis of keratoconus as well. Then obviously the irregularity of circles, if you observe again, it is going to be a feature that is seen on direct ophthalmoscopy or on slit lamp examination, that you're going to observe these different shades of circles on the layer of the cornea or on the epithelium of the cornea. Then what are the photokeratoscopies that can be observed? It's basically a forme fruste subclinical form of keratoconus, in which it is in the initial stages of the development of the abnormality in the shape. You regard it as the development of forme fruste. Then we have a Munson's sign. What happens here when you ask the patient to look in the downward gaze, the lower eyelid is it appears to be bulging. So this effect is known as the Munson's sign or the positive Munson's sign, and it also points out towards the diagnosis of keratoconus in these individuals. Then obviously the development of keratometry, again, you should know that 45 diopters is the normal reading of the keratoconus, of the layer of the cornea. It's a normal reading. If there are any larger readings, for example, if it's a mild keratoconus, the readings are going to be less than 48 diopters. If it is a moderate keratoconus, the readings are going to lie between 48 and 54 diopters. And if it is a very severe sort of keratoconus, it is going to be almost more than 54 diopters noted down in these individuals. The morphological classification of the keratoconus is going to be abbreviated as you can have a nipple cone keratoconus. Again, it's basically depending upon the size of the keratoconus or the bulging phenomena of the corneal epithelium over here. On one hand, we have a very mild keratoconus, which is basically termed as a nipple cone keratoconus. It's very small in size, almost less than 5 millimeters, and steep curvatures are noted down in this kind of cases. Then we have an oval cone keratoconus. In these cases, it's larger as compared to the nipple cone variety, and it is quite ellipsoid in shape in these individuals. And then finally, we have a globus cone also seen. It's quite large, almost more than 6 millimeters, and it's almost a globe-like shape that is observed in these patients. So this is a kind of a clinical classification, also termed as a morphological classification in these individuals. The ocular associations, when you have these patients and you have a definitive diagnosis, or sometimes you cannot diagnose a very mild keratoconus, these patients usually have ectopia lentis, and sometimes this kind of a presentation is associated with the development of keratoconus. Then we have vernal keratoconjunctivitis, which is basically a viral variety of the keratoconjunctivitis, which is again associated with keratoconus. It's usually a coupling phenomena seen in this case. Then finally, we have retinitis pigmentosa. As we all know, it's basically a degenerative process that is occurring at the retina, and it is sometimes also associated with the development of keratoconus in these individuals. Finally, we have aniridia. Aniridia is basically a term which is used for the absence of the iris in an individual. Usually, this kind of a condition is a hereditary condition which is occurring in the individuals, and it is sometimes linked up with the development of keratoconus in these individuals as well. Then we have congenital cataract, and patients presenting with congenital cataract also present with keratoconus as well. Some associations are also the systemic associations with the development of keratoconus. It can be Down syndrome, which is an atopic condition. Then we have the Ehlers-Danlos syndrome, which is basically a connective tissue disorder. And it is basically related, it's again a hereditary or a genetic problem, and is sometimes coupled up with the development of keratoconus in these individuals. Then we have osteogenesis imperfecta, in which there are some abnormalities with the development of the bones. So over here, in Ehlers-Danlos syndrome, it's basically the major presentation over here are the loose joints. And over here in osteogenesis imperfecta, we have the development of the bones that is affected primarily, not the joints. So all of these conditions, all of these hereditary conditions can usually be coupled up with the phenomena of keratoconus as well. Sometimes the patients are suffering with Marfan's syndrome, which is basically again the development, or basically you have longer bones than normal. So this is one of the phenomena, one of the hereditary and one of the genetic conditions that is again seen in people who are suffering from keratoconus. And then finally, the mitral valve prolapse, which is also known as the click murmur or the Barlow murmur phenomena, and is again sometimes associated with the development of keratoconus in these individuals. So we have the complications which are associated with keratoconus are the acute hydrops, in which the Descemet's membrane is also involved, or either it can be the development of excessive lacrimation and pain. It can be the corneal edema, or either it can be the photophobia, intolerance to the exposure of light, and defective vision or a blurred vision is the final complication that is seen with keratoconus. The treatments or the treatment modalities available out here are the spectacle correction, or either you can ask the patient to use the specific rigid lenses, which are also known as the Rose-K lenses. Sometimes we have the intacts, and they are the permanent lens replacements. And then we have the corneal collagen cross-linking phenomena, in which basically you repair the collagen of the cornea. As well as we have the DALK, which is basically a deep anterior lamellar keratoplasty. It's an abbreviation for that. And then we have a penetrating keratoplasty. So any of these variants can be used for the treating the cases of keratoconus. Another variety is known as keratoglobus. This is another form of an abnormal shape of the cornea. There is going to be not just an axial protrusion, rather there is going to be a whole protrusion of the cornea involving the periphery, involving the axial structures of the cornea as well over here. So the features are the familiar, it's basically familiar, hereditary, bilateral congenital condition, hemicephalical protrusion of the cornea, autosomal recessive inheritance is associated with it, and it can be differentiated from the congenital ophthalmos quite distinctively over here. Then we have the keratoconus posterior. It's another variety for the development or the presentation of the abnormal shape of the cornea. As the name is indicating, this is going to involve the Descemet's membrane, and there is going to be an inward protrusion rather than outward protrusion, as we saw in keratoglobus and keratoconus. So it's one of the variants, and which can be seen. It's not quite common, but you should know how to manage these cases. Again, we can perform keratoplasty procedures on cases of keratoconus posterior as well. So over here in this lecture, we just summarized the different abnormal shapes of the cornea and what are the conditions, or what is the idiopathogenesis towards the development of these conditions. So that is the end of this lecture. Thank you for watching sqadia.com.